We are down to the home stretch here. Two more presenters. One theme that's just really emerging to me that's so powerful is this idea of, we used to talk about how capital is an airplane and you have to but a community needs to create a landing strip. And in almost every single conversation so far, it really is this discussion that Scott kind of closed us out on about the idea of local capacity. Rob and Aaron were talking about that earlier. So we're going to have these last two presentations. I'm going to make a little bit of a change to the agenda. I'm going to cut that break and see if we can't get out of here a little bit earlier. And then in the last talk, we said it was going to be a book talk, but it's going to be a Q&A between Nicholas Hazard and me before we go out to the reception. So now it is my great pleasure to introduce Ruth Thomas-Squants, who is an old friend and just such an interesting person. I mean, she's got a PhD in biochemistry. She's got a master's in public health from UC Berkeley. She is enormously dedicated to the issues that we are really focused on here. She has been working very hard on this rural playbook issue. Rob earlier, Rob Riley had mentioned that there was talking about a hospital investing in one of his local areas. It was kind of foreshadowing what Ruth was going to share with us. But you're really in for a treat. This is hot off the press. This is literally, the primer is out today. And so this is your first chance to hear about it. And a little known fact about Ruth, and we have some handouts so you can get with the QR code so you can download the report. Ruth is fluent in Welsh, and lots of people in Wales aren't even fluent in Welsh. So that's really impressive. Ruth, welcome.
Thank you for that kind introduction, David. Actually, can you hear me? My highest qualification is that I come from a rural village in Wales with just 3,000 people. So I'm on the right topic and in the right place. Hi, everyone. Thanks for sticking with us today. Thank you to the organizers for inviting me to talk about our new playbook for rural development. Oh, here we go. It's a playbook for new rural healthcare partnerships, models of investment. As David said, my name is Ruth Thomas-Squants. I am the Senior Director of Field Building at the Build Healthy Places Network. And we're a program of the Public Health Institute. And we're a national center working at the intersection of community development and health. And our mission is to transform the way organizations within these sectors work together so they more effectively reduce poverty and advance racial and health equity across the country. So today I'm going to talk to you a little bit about connecting place and health, the role of healthcare in community investment, a little bit about the playbook, the Rural Playbook for Healthcare Investment, and some of the strategies and cross-cutting themes that emerge from that work. I'll share a couple of case studies and finish off with a brief look ahead. So health happens in neighborhoods, and the question is why someone with my health background would be speaking today. So I'll start by setting the context of this definition of health, of being a state of complete mental and social well-being, and not merely the absence of disease or infirmity. And this comes from the preamble to the Constitution of the World Health Organization from back in 1946. And it really encourages us to move away from thinking of health in terms of absence of disease and thinking about that more holistic well-being, physical, mental, and social well-being. So I'll start by with that definition in mind, I should say, the US has very high levels of spending on healthcare. We spend just over $4 trillion per year on healthcare. And the vast majority of this, about 85% actually, goes on chronic diseases. This is things such as asthma, heart disease, diabetes, and many of these are actually preventable. And many chronic diseases are experienced by low-income people living in low-income places. So what you see are large sums of money, large sums going on largely avoidable costs that can be created by conditions in the environment associated with poverty. And the spending is not really quite working out as good value for money. So this, I promise, is the only graph that I'm going to show, even though I'm a scientist and I love them. So one marker that we can use for health is life expectancy in a population. And this graph shows the relationship between health expenditure, which is along the horizontal axis, and on the vertical axis, you've got life expectancy. And all you have to do is follow that red line at the bottom to see that despite the large amounts that the US invests in healthcare spending, this does not lead to great outcomes on health expectancy. And on the surface, it's a bit of a confusing result. So research has found that there are many factors contributing to health outcomes. When we look at this chart, at the contributions to premature death, we can see that premature death is impacted by many different factors: behavioral patterns, social circumstances, your genetics play a role, and environmental exposure. And healthcare accounts for about 10% of those outcomes. So what is happening is that about 95% of our healthcare dollars are going towards this little slice of what impacts premature death. So what we've learned then is that people get sick because of their social and physical environments. Factors such as your education, the job you have, whether you have access to places to exercise, if it's a healthy outdoors, if you have access to fresh fruits and vegetables, the quality of your housing, access to transportation, all these kinds of factors together have an impact on your health, and this is all outside of the clinical delivery system. So these are called social determinants of health by those who like to use such long terms. And what we also see is that the distribution of resources of power and money shapes some of these environments and these factors. So what we know is that these factors literally affect your biology, and the accumulation of toxic stress associated with extreme or generational poverty, food scarcity, things like risk of violence, loss, grief and loss, the lack of control of agency to change your own life, they all have an impact on one's health outcomes. And more recently, the field is adopting a sort of a holistic framework, which I'll just mention here, called the Vital Conditions for Wellbeing. And this is part of Thrive Together project from the Wellbeing Trust, Rethink Health, and community initiatives. And this really emphasizes this multifaceted nature of our systems that combine to influence community health. So it helps us think about what levers we can use to change, for community change that can actually help improve conditions. So the factors are grouped into these 7 domains, and within those domains, they all have indicators. And I'll just, run through a couple of them. Things like the domain on basic needs, health and safety. Within that would have indicators like adequate clean air and water, nutritious foods, and then actual access to healthcare itself. Meaningful work indicators, such as contributing to personal, family, and community wealth. And then you have things like humane housing, which covers provision of safe and stable places to live and vibrant communities. And that would have indicators such as home ownership, complete streets, and housing affordability, and that kind of thing. So just even this glance at the domains and the indicators, you can see that many ways those that are working to create the built environment, community development, community economic development, are in fact impacting these vital conditions for health. So what the data tells us is that your zip code is more important in predicting your health than your genetic code. So where we live and where we grow determines our health outcomes. And so why is that important to our work and what I'm going to talk about today? So we see opportunities to deepen the impact on community health through upstream investments that impact these social drivers and the vital conditions that I talked about. So in this image, you can see the lower portion of the stream, that below the bottom line. These interventions are called downstream, and they focus on the individual. So things like providing clinical care, direct care. And if you take it a step up, these interventions also impact at the individual level. And this refers to what we're seeing as sort of more increased practice in healthcare, where we screen patients for social factors during the clinical interaction, like connecting them to food, or whether they need housing services, just depending on an expressed need. So then if we take it to the top of the image, the upstream investments, and that's what I'll be talking about today, seeks to influence at the community level. So this opportunity we see is for healthcare to impact through community investments which address the root causes of disease, influencing the factors driving the needs that you will see further downstream at the individual level. And for healthcare to achieve this effectively, this will require non-traditional partners, and I think that includes the community development sector. So I'm going to pivot just a little bit to take a look at the challenges that are being faced by rural healthcare specifically. And even before COVID-19, rural healthcare has been facing some serious challenges. There have been demographic shifts that have resulted in shrinking and aging populations, which means that there are loss of patients for the health systems with negative effects on the financial projections. This impact is particularly pronounced with cost containment shifts as we move to value-based care payments, and these limit payments and prioritize managing patients' conditions and keeping them well. So while this shift to focus on prevention is the right direction for investing in health of communities, rural health systems often can't keep up. So this is reflected, really, I think, in what's a fairly alarming number of hospital closures, with over 100 rural hospitals closing in the last 9 years, with more at risk. So laid on this is also their important role as employers in rural communities, and they struggle with being competitive on recruitment and retention, and this is directly impacted by things like availability of housing and childcare. So community investment, what's healthcare's role? So as well as offering assets for holistic investments in health, the unique challenges rural healthcare faces really makes partnership for them a win-win proposition. Healthcare sector in rural geographies really represents a very influential partner in efforts to build healthy communities and resilient communities. They play an important role as major employers and also as consumers of goods and services in their area. They are sources of critical community health data insights for effective impact. Several of the examples we spoke to in creating the Playbook cited their community health needs assessment as being foundational to the project's success. And then finally, for them, really creating community conditions that support and retain vibrant communities is really essential for their continued success and rural health systems. So how we got here, I think first, the real answer that's not on the slide is with probably every webinar or presentation that we gave on multi-sector partnerships, we'd get the question, how does this work in rural? So we began this process really with a rural roundtable, and Caitlin, who spoke earlier, was a part of that table, as well as other national rural leaders representing the healthcare, the public health, and the community development sectors. And really following a very rich discussion and information we gathered through this process, I think we concluded that our value add would be to build on existing resources like the Investing in Rural Prosperity book and creating a resource to support bringing in rural healthcare to this multi-sector partnership perspective in a way that would be effective to bring inclusive decision-making and some of those principles that Andrew spoke about this morning. So today, as mentioned, the plug was that we released our Playbook for Rural Healthcare Partnership Models of Investment. And so if anybody, the folks who are actually physically in the room here, you can get the flyers and access through the QR code. For those that are virtual, you can access directly from our website, the buildhealthyplaces.org. And through this process, as we conducted interviews while developing the case studies and conducted research and collated information from the advisory board discussions and the roundtable, we began to formulate some broad strategies for rural healthcare partnerships with community development as well as other stakeholders. And I'll go through some of the strategies briefly and then share some examples that we have in the playbook. So briefly, the first one was strengthening economic opportunity and workforce support. That included things like workforce development and, as I mentioned, access to childcare and housing. Supporting local control, and this we'll see through some examples on community ownership and land trusts. Strengthening infrastructure to support healthcare access. And then finally, increasing resources through capital, funding, and then access to other government resources. And so to be clear, in practice, the projects we highlighted, and some of them, that I'm going to share here, they don't all sit discretely in these buckets in reality, as seems appropriate. But these frameworks were sort of helpful in sort of conceptualizing the work and the possibilities when considering embarking on these partnerships. So I will share some case studies to highlight the strategies. So the first one is strengthening economic opportunity and workforce. And we really saw economic stability and community health as really two very interdependent factors. We heard about the role of healthcare plays as this sort of gravitational center of economics, being an anchor institution and often the major employer in the communities that they're in. So rural healthcare is a significant economic driver in the communities that surround them. And as I mentioned, with economic stability being such a major factor and impact on poor health outcomes, there's this interplay between the fate and stability of rural healthcare institutions, both as the service providers and employers and economic drivers. So we see strategies that embrace this role, driving workforce development strategies, strengthening career pathways, or indirectly through creation of that workforce housing and childcare that I mentioned earlier. So both pretty important factors for rural healthcare when they're trying to compete in terms of recruitment and retention. So this particular case study is for Skylex Medical Center and Klamath Works in Oregon. And Klamath Falls, Oregon, is a rural community of just over 21,000 people. The unemployment rate there remains high, above the state averages. And what Skylex Medical Center did was they banded together with Klamath Works to build the Klamath Works Service Campus. And the idea of this was a vision for really convening a space for nonprofits and sort of related social service agencies to produce a community wellness hub that would have services like detox and sobering station, mental health services, Medicaid managed care offices, and also a jobs program. And the goal really is that this social hub will provide a space to empower community members through employment and social services that will foster a sense of self-worth and a certain sense of agency and self-sufficiency. And the medical center's contributions so far have been, the purchase of an 18-acre parcel of land that's next to the community's federal qualified health center and near a childcare facility that will also serve as the location for this services campus. They also did a land swap with Klamath Works to provide 2 acres of this parcel to build the gospel mission, which will have emergency shelters and commercial kitchen. They also provided seed capital of $50,000 for the buildings, and then also provided these letters of support for additional grant funding, which is another important aspect. So they're continuing to fundraise for the grants to pay for additional job trainers on the site and new infrastructure. And this is just an image of the site of the land that was built, the land that was purchased for the building of the campus. So the next strategy is supporting local control. So some rural healthcare institutions are supporting community ownership models that help close racial wealth gaps to reduce health disparities. And so these models really include those that support collective ownership through vehicles like land trusts, or things such as promoting, alternatively, it can be things such as promoting food sovereignty, which really moves from beyond food access to healthy, culturally appropriate foods that could be defined by a community's own agricultural system. And then finally, another one that we grouped in this supporting local control are policy changes that advance community investment or needed land use changes. And the example I'm going to share of this one is from Idaho, and St. Alphonsus Health System is a nonprofit system with five hospitals in Idaho and Oregon, and it's a member of the Trinity Health Catholic healthcare system. And they created a community health and well-being department, and one of their investments has been a contribution to Idaho's first land trust. So their community needs assessment had indicated that housing quality and affordability were the biggest areas of concern. So the first affordable housing developments as part of the trust were in fact located in urban Boise and has since been expanded to create opportunities for home ownership in rural parts of the state. They worked with a local nonprofit organization, LEAP Charities, and created this LEAP Housing Trust, which is going to be using this land trust model. So, and in this, the homeowners own their homes while the trust retains ownership of the land. And so it allows homeowners to gain some equity from the rising prices to a limit, while guaranteeing that the properties remain affordable when sold to the next buyer. So St. Alphonsus became the first investor in the land trust using their community benefit dollars, and then hospital foundation funding, as well as grant funding intended to address social determinants of health that I mentioned earlier. So the project in Mountain Home, Idaho, is a community with about 14,000 residents, and the planned properties will include wraparound services for residents, and they're considering options such as on-site residential service coordinators. So the rural communities near Boise is an example where they're experiencing a population boom, and that spillover from the sort of massive housing price increases that they're seeing in Boise have folks moving out of the urban areas, and this kind of creates a threat of displacement for current residents and the affordable housing stock. So actually what they found when bringing in this model to the rural communities, there was initial concern and resistance around not preserving agricultural land and replacing open space with new infrastructure. So St. Alphonsus worked with the community to illustrate data with relatable storytelling and created a broad coalition of trusted local partners who championed the work and really shaped the messaging so that it resonated with community members. And then we got this quote as we interviewed Rebecca from St. Alphonsus, that we bring data for the head and stories for the heart. And this is an image of one of their projects. So strengthening infrastructure to support healthcare access. So these strategies really build and strengthen community infrastructure that's necessary for effective healthcare delivery. So a concern we heard frequently as rural hospitals have to respond to the challenges of physically connecting rural healthcare to dispersed communities needing services, and that was even before the pandemic challenged all that. And some examples of this can be through collaboration with partners to co-locate services that can improve access, or as we heard earlier in the session previously, expanding the reach of broadband availability, which has really become the foundation by which we maintained healthcare services through telehealth, or improving transportation. And we have examples of all of those in the playbook, and I'm just going to talk about the last one, which was around transportation. And this takes us to New Hampshire and the Dartmouth-Hitchcock Medical Center. And this is the only academic medical center in the state. And it was one of the first partners in a collaborative effort with Southwestern Community Services. So they're a community action agency, and they needed to create a new bus route connecting the cities of Claremont and Lebanon in New Hampshire. So like St. Alphonsus in the previous example, Dartmouth-Hitchcock's initial investment of $50,000 from the hospital's community benefit dollars was really functioning as a catalyst that generated the additional funding by lending legitimacy to the project. You know, as I mentioned, these institutions have a lot of gravitational pull in the communities that they work in. And at the same time, these partners also leveraged other community-based organizations, collective knowledge, and relationships to access funding from state and federal agencies. So for Dartmouth-Hitchcock, the business case was clear. Lebanon, the location of the actual medical center, is a rural community, one of the highest median incomes in the state. While nearby Claremont is also rural, is less affluent, has more health challenges. But the communities are interlinked. And to retain and recruit the workforce needed to sustain a large medical center like Dartmouth-Hitchcock and to support their operations, they needed to prioritize access to more affordable locations where hospital staff could live. And two, they also needed to have a large volume of jobs by continuously certifying people to enter the workforce and to maintain these broad operations. So the hospitals, for example, they run a career school to train people for several of the frontline and direct care roles. So as I mentioned earlier, that recruitment and retention piece are major challenges for rural healthcare. So to maintain such a workforce, they had to prioritize affordable locations. And they saw building transportation to give people opportunities to live in communities where housing was affordable was really an institutional imperative for them. So, as the CEO of the Southwestern Community Services described it, nothing happens at the Department of Transportation level without local match. So they said that the hospital stepping in wasn't just a nice thing to do, but it would not have been possible for them to sort of start launching into these other funding sources without that initial investment. And this is not Dartmouth-Hitchcock's only investment. They are a member of the Health Anchor Network, which is a group of health systems that have pledged to allocate 1% of their investments to place-based work. But we really wanted to demonstrate the range and the types and the scales of these partnerships and investments that show up in rural areas. And they can still have big impacts locally. And Andrew had a disclaimer. This is my disclaimer that this is not an image of the actual bus, I was told. So the last strategy I'll talk about is increasing resources. Several cases we came across the strategy where healthcare investment in rural development served to increase access to resources by diversifying a project's funding base, donation of land to support community-based projects, and reaching out to community development partners that have expertise in this kind of creative deployment of capital that's needed to support housing and workforce development projects. And we've also heard, even the couple of examples I've already shared, you'll see that some of these strategies overlap. There were land swaps in some of the other examples. So the one I'm going to talk about today is the Sanford Health and the Bemidji Veterans Home in Minnesota. And rural America is a home, as many of you might know, to a disproportionately higher number of service members and veterans. And there are challenges associated with providing housing and supportive services for veterans in rural areas. Due to the geography, really limited resources and insufficient social service infrastructure. So this particular project concerns the plans that were made for 2023 for new veterans' homes in this region. And this particular location was one of several communities that were being considered for the site to meet the growing needs in the region. So a tipping point in the favor was the donation of land by Sanford Health System. This became the center of a successful campaign to build the project. And the land represented excess and underutilized property of the healthcare system and was in a location with easy access to transit and is located within reach of the medical center. So the project financing and commitments included a $10 million assembled location match to secure the federal grant. So additional funding came from the state and local government units, organizations, private donations, with a final piece being the commitment of the VA department to bring in funding to reach the total development costs of $42 million for the project. So they do have additional projects in the works. There's been further land and building donations from Sanford, And they've supported a new day centre for those in the community experiencing homelessness, and partnership with the insurer, Prime West Health, to form a new mental health facility that is being planned to consolidate and expand mental health services in the community. So the land and the building donations total over $2 million in value, and really enabled and drove the sort of housing community health projects forward in this community. And this is an image of the proposed new development that will be taking place. So as well as the case studies, there were several overarching themes that also emerged from our discussions and interviews. And some of these points you will see that really reflect some of the principles we heard this morning from the TRIC framework. A consistent factor mentioned in the successful projects was the importance of the trust and relationship building in advance of making investments. And this could be said of multi-sector partnerships wherever they take place, I think. Leveraging this social capital led to information exchange and cooperation that really propelled the projects forward. And this can sometimes require intentional bridge building, especially with disenfranchised communities, to ensure success and sustainability of the projects in the end. And part of this process includes the centering of community voice in both defining the problem as well as creating the solutions. So building on the point I made earlier about bridge building, engaging in an inclusive process is necessary for our vision of shared prosperity and health equity. And this really, I think, requires us to pause and intentionally interrogate where we may be continuing systemic biases or perpetuating systems that have systematically excluded some groups from rural communities more than others. And so, as I mentioned in the Vital Conditions Framework, centering belonging and civic muscle can be considered foundational, really, across all the strategies and approaches that we've spoken about today. Because giving agency to communities to drive change is more than just a nice to have, and it really fundamentally shapes the outcomes that you get, the community engagement, and ultimately the sustainability of your project. So we also propose that, as some of the projects in the Playbook already have, and I've mentioned some of them, healthcare can really support innovative advances in community engagement in rural areas, driving community solutions, and engaging in community ownership of projects. Direct participation is key to grappling with these pervasive challenges that impact health and wellness. So, why multi-sector rural health partnerships as a whole? And I think in summary, we could sort of say that we really feel that it plays to the strengths of rural environments. It builds on the sort of interconnectedness and close-knit ties that you see, utilizing informal networks to bridge formal sectors in a way that's very effective, allows leverage of strengths from natural networks that thrive in rural areas. And it also facilitates combined efforts to address the challenges in attracting capital that we've heard about repeatedly today, that these combined efforts make a more, especially competitive applications. Small investments, we've heard in some of the issues in competitive attraction of capital is that they can't compete on scale, but the flip side being that small investments can really have big impacts in rural areas. And this really allows also for community knowledge to drive the solutions. I think we've heard it through various iterations of the different sessions this morning, that solutions generated from communities that have the best knowledge of the barriers to success are the way to sort of increase effectiveness of the projects that we're trying to reach. So I think you can see through all of these, actually, that the threads of the TRIC framework from this morning, really, in terms of creating tailored, intentional, inclusive solutions, that will collaborate with the community. I think that's important. So I will finish with just a brief look ahead, and I think especially in the context of the things that are happening at the moment in terms of the infrastructure bill and the investments that are coming that are geared towards rural. I think we see an opportunity that the hospitals will support local policies such as zoning and land use, housing development and local economic development that prioritizes health and well-being. Hospitals can create new ways to drive community engagement that centers the needs and priorities of those that are most impacted by historical and persistent inequities. There are new data collection and sense-making methods that will allow for disaggregation of data to really support the community voice. And hospitals can embed their community investments over and above community benefit requirements and use innovative, non-traditional sources of funding with new partnerships from different sectors. And as a result, I think we'll see community development sectors as a go-to partner, really, in this sort of process. But then hospitals will also embrace and build on anchor strategies around inclusive, local hiring, workforce development, local purchasing and procurement, and support to local businesses. So I'll finish with another plug for the Playbook for the Rural Healthcare Partnership Models of Investment, which you can check on our website. This is the Build Healthy Places Network website. I encourage you to go take a look, buildhealthyplaces.org. We have a whole host of information, tools, and resources that are designed to support cross-sector partnerships to impact health. This is a previous playbook that we developed that's a healthcare playbook for community development, so communication from the other side. We also have things such as a jargon buster, which sort of fulfills the function of sort of international relations, translating common terms that lead to mishaps. And the community close-ups are a series of case studies that really go in depth and the nuts and bolts about how some of these projects and partnerships came to be. And so I'll just finish with some contact information. You can check the Build Healthy Places website. We're also on Twitter and LinkedIn. This is my email address. I'd love to hear from you and hear from these kind of examples and case studies. I'm also on LinkedIn. You'll find me. And I'd like to thank you all for your attention today and everybody online. Thanks very much.